Hi everyone, my name is Yi. Welcome to Occupational Medicine Pearls podcast. Today's episode is about excessive daytime sleepiness or EDS, and I would also like to talk about shift work, sleep disorder, or circadian rhythm sleep disorder because these two are quite related and very important for occupational health and safety. All right, let's start with that. Starting with knowing the definition. Excessive daytime sleepiness is called when there is inability of a worker to maintain wakefulness during the major waking hours with an intended lapse into drowsiness or sleep. So if I am falling asleep during the day without intentionally and I can't keep myself awake, it is called excessive daytime sleepiness. It is important since that could signal for presence of obstructive sleep apnea, narcolepsy, or any other sleep issues. Compared to that, fatigue. So fatigue is a subjective state of tiredness, we can call that. If we want to give it slightly more formal definition, according to the code of practice, we can say a state of physical, mental, or emotional impairment that can develop over the short or long term and preventing someone from functioning safely and has health effects. And it doesn't include chronic fatigue syndrome and pathological fatigue from other medical illness from the code of practice. So that to make it clear that they are different, and we generally call tired or tiredness. Tiredness can be a lay term and it is non-specific term. It doesn't translate directly into excessive daytime sleepiness. There are a couple of concepts that I would also like to cover. The first is sleep debt. So it is accumulative shortfall of sleep over days, weeks, or years, which is common in shift workers, FIFO, parents, and people on multiple jobs. And sleep inertia is another concept. It is the feeling of grogginess immediately after waking, and especially from the deep sleep, and that can have relevant effects on how it take you to get going after waking up. Is excessive daytime sleepiness or sleep deprivation important? Yes, it does. And up to about 15% of Australian adults report that they have problematic EDS, and also sleepiness contribute to maybe 15-20% of fatal heavy vehicle crashes in Australia, and car crash risk double after continuously waking awake for more than 17 hours. And the research stated that if someone is awake for 24 hours, their blood alcohol concentration is similar to the level of 0.10%. So that's the level of impairment. From occupational risk group, we can see that it is prevalent in long-haul commercial drivers, rail safety workers, FIFO and mining shift workers. Obviously, healthcare workers, nurses, doctors, and junior doctors in particular, aviation crew, maritime, watchkeepers, emergency service providers. That's more from the occupational perspective. Now you would understand that why the accidents happen in these critical workplaces can have significant consequences and the importance of this occupational health issue. So what are the other causes or contributing conditions that make people to have excessive daytime sleepiness? So this is a medical list or medical condition that can cause people to have the symptom. We can have group them into multiple category. The first one is sleep disorder breathing. They would include obstructive sleep apnea related due to physical obstruction, related to obesity, and central sleep apnea due to opioids or any brain related condition, high altitude or heart failure, obesity, hypoventilation syndrome called Pickwickian syndrome. So that's sleep disorder breathing. The next step is that primary hypersomnias, such as narcolepsy, idiopathic hypersomnia. So they are rare conditions, but still present to consider. The third is probably the most common, insufficient sleep. If you don't sleep, either due to choice, work, care responsibility, study, or social, and then even without having shift work, that can create sleep problems. The fourth is that circadian rhythm sleep wake disorder. That's where shift work related sleep disorder come in. and that may also be seen in the jet lag disorder. And the fifth option is sleep-related movement disorder, such as restless leg syndrome, interfering with your sleep. And further down to substance and medication related, sedative medication, alcohol, antidepressants, opioids, antipsychotic, cannabis, they can interfere with your sleep by either keeping you awake or causing too much sedation. And medical conditions such as depression, anxiety, thyroid, anemia, chronic kidney disease, chronic liver disease, advanced diabetic. So they can be causing people to have sleepiness. Neurologically, condition like Parkinson's disease, dementia, multiple sclerosis, post-stroke, post-concussion can have impact on the alertness. So these are the conditions that we need to go through as a differential diagnosis. One, we have to assess someone for considering a person's fitness for work. And when we ask history, physical examination, bedside tests, that is where our question will be focusing. So that seems straightforward. If you have the condition in your head, you can ask them and you can make sure key points are not missed and the history need to be very thorough. In terms of bedside or questionnaire-based tools, so there are other tools that we can use. In Australia, Epworth Sleepiness Score (ESS) is commonly used, and the other aspect is stop bang scoring. Stop bang is a lot more useful and it is more sensitive since it covers other physical examination finding in addition to self-reported items. With ESS, more than 10 is abnormal and more than 15 is strongly pathological. So the test itself is valid and sensitive, however, it requires self-reporting, so you would imagine people would enter report. And with the stop bang, how we can use them to measure people's blood pressure, BMI, or their neck circumference, and that will help us with our risk assessment. We can ask to do sleep diary, usually 1 to 2 weeks duration. That is people writing down what time they wake, for how many hours they sleep, and in terms of wake time, do they have caffeine, alcohol, or any midday naps. So that is very easy. The difficulty is that people may forget and it suffers from recall bias. And you may think that you slept 7 hours because you feel tired, but it may well be that they have slept 10 hours. So it varies. To get more accurate measurement, we have a couple of ways. The first is that actigraphy. So this is wearing a watch, a band on your wrist, and that measure the sleep and movement. It tell you the duration of sleep, it doesn't necessarily tell the quality of the sleep. The gold standard for OSA diagnosis, in particular with commercial driver, is that lab-based polysomnography, PSG. So that's really good to do. However, the physical availability of the test could be limited in many settings or workplaces. So we can also do level 2 home sleep study, and that can be used for initial screening. For the assessing safety critical worker, if whether they can remain awake to do the job, we can do maintenance of wakefulness tests. We can order them and they require the sleep specialist input to perform adequately. To do that, there are a couple of things we have to start. The first is that checking or declaring if someone had any sedative or alcohol the day before, and then they do the lab-based polysomnography, and the next day we would have 4 trials, and each trial would be like 40 minutes long, and the worker is spending time in a dim, quiet room, and they have to try to stay awake. That sounds like quite challenging, but they need to prove that they can perform to stay awake. There is another test called multiple sleep latency test, MSLT. That's the other way around, where the people can go back to sleep when there is opportunity. There are 5 times during the day, and that is done usually to assess if someone had narcolepsy. If we have to summarize, if the history suggests there is obstructive sleep apnea with snoring apnea, and the polysomnography should be the next step. If the history suggests narcolepsy, and then it should be polysomnography with multiple sleep latency tests. If a worker need to demonstrate that they are able to or they're fit to perform safety critical tasks on treatment, and then there may be maintenance or wakefulness tests. The name is self-explanatory. However, if we don't have anything, however, we suspect shift work disorder, and then we can use a combination of sleep diary and actigraphy. That is quite easy to perform compared to other tests I mentioned before. Blood tests or other investigation, they're plentiful, and that is quite dependent on your clinical reasoning and your question. There is no essential or mandatory test, so rely on your clinical reasoning and you will get job done. How do we manage them? Well, the first general principle is that treating the cause. EDS itself is not a disease or a diagnosis. It is a symptom, or it is a flag telling me that there is not something is not right with the worker's presentation. So, but there's some general principle we can advise to everyone, even us can apply to us. The first is having a sleep hygiene. It is an essential thing to do, but it is not solution to fix all the life's problems. So what is a sleep hygiene? Well, we just sleeping as we humans should be instead of trying to do too many things with the modern lifestyle. So that is a good sleep hygiene. So we use go to bed when we are tired, and then we only do that for bed for sleep and sex. That's what we always talk about. Don't do like reading or playing video games or watching TV. Avoid caffeine or alcohol in the evening, and avoid screen time when it is too close to the bedtime, and sleeping at the consistent schedule. They are usually what is good sleep practices. If there are other medical conditions, treating them is important. One other aspect that is useful is that general physical activity. If people are not having moderate, at least aerobic physical activity, that would be helpful for overall health, not just related to the sleep. So that's as much as I want to cover for excessive daytime sleepiness. The next topic I want to cover is shift work sleep disorder or circadian sleep disorder. There are different diagnostic criteria to meet the definition. However, the main principle is that someone or a worker has insomnia, which is that you can't go to sleep or you feel too sleepy and you have total reduction of your sleep time. So you're not sleeping enough, but you may, and that is associated with or due to recurring work schedule, and that is interfering with your normal sleep time. And these symptom or these work schedule has to be lasting for at least 3 months, and that is an essential requirement before we diagnose someone. And we have log their sleep duration by using sleep diary or actigraphy for at least 2 weeks, and it is demonstrating that the sleep is not adequate and there is multiple wakeful periods at the nighttime. The other important part is that there is no other better explanation by another sleep disorder, medical, neurological, mental disorder, medication use, poor sleep hygiene. Otherwise, we would call them as these disorder instead of shift work related sleep disorder. And the scale of the problem is also quite common in Australia, so we need to be aware of. So this is a condition that everyone who works with shift work can experience. So this is not like a rare condition that a certain population of the worker will experience. So we have to assume that every worker who perform shift work can have this condition. It's a matter of the severity on a spectrum. And from the occupational health perspective, that is important since we have to look after the whole workforce, and our preventive strategy or control strategy need to apply to everyone. And what are the mechanisms? Why do people can't sleep or they feel tired when they do shift works? So there are some theories. I think it is more of a mechanism that explain. The first is that our sleep rhythm become misaligned with what our body clock is supposed to do, and we are controlled by light, and we are supposed to sleep at nighttime when the light is present. Since the discovery of fire and artificial lights, that distinction is not as clear as it used to in the Stone Age. Now, nighttime people still working as they do in the daytime, so especially working at nighttime disrupt our circadian rhythm and the time where we are supposed to be resting. And because of that, our sleep is shorter, typically 1 to 4 hours less per 24 hour, and it became more fragmented with reduced REM sleep. And the second mechanism is that failure to adapt. There is assumption that if someone is doing the same type of shift in the evening or nighttime, they will get used to it. They could, but it is rare. In fact, less than 5% could adapt to the shift rhythm completely, and most of the workers don't. And that is important to understand that we can't rely on adaptation to as a control mechanism. And when we do shift work, rotating shift or forward or backward shift, what happened is that we start to feel tired after the second or third day, and you can feel that your some of the thought process are not clear, and you're essentially relying on stimulants such as caffeine to keep going. Because you are suffering from cumulative sleep debt, it is not avoidable. And because when you do the shift work, you have restricted or less opportunity to sleep, and that become causing impact on your neurobehavioral things, so it can cause impairment. However, if you are someone, they will always underreport or underestimate the level of impairment since they are the one who is impaired. You can't expect them to tell the difference. They're also individual modifier if they have already quite sensitive to sleep deprivation or age. And when you get older, your tolerance gradually get lower. If there is comorbid sleep disorder, responsibility or childcare duties at home, so shift worker with young family can have the largest impact because of that. How long do you have to drive after shift work? Some people need to go to 1 to 2 hours of driving after the shift. That is quite dangerous. Do they have any job during daytime that would gonna keep their attention going? So they are important points to consider. Now we know that shift work is not good. So what are the actual evidence that tell us what sort of hazards or problems? We already know sleep disturbance. From occupational point of view, we start with injury and error rate. That can be minor, near miss to catastrophic outcomes. So that is important. We need to control that. Other part is ischemic heart disease and type 2 diabetes and obesity. So these are something that will happen gradually over time for people with long-term shift worker. The evidence overall is moderate to strong. So the odd ratio, interestingly, in male based on a paper that we did before was 1.5. So interestingly. And there is also increased risk of cancer. So IRC classify the shift work or night shift work as group 2A. So what it means is that it tells the potential or the risk of cancer probable in human. However, it doesn't actually tell us the level of risk of having the actual cancer. What type of cancer? There is breast cancer, prostate, colon, and rectum. The evidence is sufficient in animals, but it is considered probable in humans. Other conditions such as pre-existing epilepsy, depression, or anxiety will potentially get worse. People will develop reliance on the narcotics or sedative to sleep them off. People also have increased risk of musculoskeletal injury due to physical fatigue and also just from slowness from the effects of the sleep deprivation. The last one is a reproductive health. So there is evidence that sleep work or night shift is associated with increased chance of preterm birth, miscarriage, and reduced fertility. So these seems like a lot of significant impact on human health. How do we control that? So hierarchical control is important to consider. So starting with elimination, can we eliminate the tasks to the daytime? So arrange the non-essential tasks, so the tasks that could be wait and done the daytime. So only let the minimum number of people perform the night shift or evening shift to minimize the impact, and automate the task. So that would be quite good. From the substitution engineering, we treat that as a psychosocial hazard, which means that we would look at workplace design, a job design, or roster design. There are parameters that we need to know, and Safe Work Australia Code of Practice has multiple parameter, and there is a minimum recommendation as a benchmark. Obviously, these are not law, but they are based on the recommended safety critical mark. So if a business is not following that, if anything goes wrong, and this can be shown as they are not doing their due diligence to protect the workers. So work time is that work should not start before 6 o'clock in the morning or end after 10 p.m. at night. Since risk rises after 10 p.m. and usually between morning 2 to until 6 is highest. Consecutive night is not more than 3 consecutive night shifts and not less than 12 hours between shifts. During the shift, there should be at least 30 minutes break every 5 hours. And when we are looking at the consecutive days, so not more than 5 days in a row. So between the blocks, there has to be at least 2 consecutive night sleep opportunity. And when we are assigning someone to night shift, let them know at least 24 hours in advance. When we are looking at the rotation or shift design, forward rotation from day, evening to night is a lot better than night, evening to day. And the rapid rotation is also better than longer. Rapid rotation is that doing this 1 to 3 type of shift in a row instead of, let's say, you doing the day shift 7 days followed by evening shift of 7 evening and followed by 7 night shifts. So this is quite long shift of that. So the ideal recommendation, it's not the best, but the best we can come up is rapid forward rotation of the shift is probably the best option. Shift length is always contentious, but ideally it should be 8 hours. But we have work who are done 12 hours as well. So when we are designing work, the condition like shift handover has to be done within the shift, not after your shift ends. Shift swapping should be controlled by the central who can monitor people's accumulated sleep debt, and the workplace should have policy on having a second job. Now there is a difficulty that you can't enforce people to not to do second job, but at the same time, this is the area where people should be communicated about the reason for not allowing the fatigue to build up too much. And if we're thinking about FIFO workers or people who are long distance, have to travel after shift, having houses or accommodation near the workplace is a good way to minimize the road traffic accident as well as the buildup of fatigue when they return. So these are the higher level control. Administrative controls are still done, but they have less impact than the higher levels. So many workplaces are either legislatively or they created their own fatigue risk management system, and they are designed to look at the how work is done and try to have systems so that they prevent people from accruing too many or too much fatigue during the work. There are newly developed or many fancy gadgets that monitor drivers, and if you fall asleep or if you start dozing off behind the wheel or if your steering wheel start to move in some particular pattern, it wake you up or make a loud noise or cause vibration to the seat to wake you up. So they are good, but they are good for monitoring. However, they don't prevent you from developing fatigue. They only kick in when you start dozing off when you're tired. So they can't be regarded as a good control. The other factor is that in the administrative control is that shift penalties that people tend to get, more money or higher salary for performing shift work. That is not a control either. And that is in fact longer shift, and people might be doing more night shift so that they get paid more, and that is rewarding that type of behavior, and that is counterintuitive from safety perspective. But at the same time, the workers' representative might be argued that it is better for financial well-being of their members. But as an occupational health practitioners, we need to know that where we stand from safety perspective. There are also other individual counterparts. Though obviously, there is no PPE for preventing falling asleep or sleep disorder. Perhaps we could put a nice pillow, but the individual countermeasures are also important. So what can we do? We can apply basic principle, as I mentioned before, having a good sleep education or sleep hygiene, trying the cognitive behavior therapy or CBDI, or for the people with sleep disorder. So they are important to have them. Medications, well, that go beyond the scope of occupational medicine. So medication like modafinil can be prescribed by the sleep specialist for sleep shift work, sleep disorder, but they need to prove that the medication is compatible with safety critical work. All right, that's a lot of me talking nonstop. I hope you find this episode useful, and I will talk to you later.